Good evening. Thank you for this opportunity. It's very humbling to share this space with legends like Dr. Rao, who's actually been partly someone who inspired me to do community ophthalmology. I hope that in the next few minutes, I can walk you through the concepts of effective refractive error coverage and WHO SPECS 2030 initiative. At the outset, I want to acknowledge Dr. Stuart Keel, who has kindly permitted me to use some of the WHO graphics to explain this to you. Universal health coverage has been identified as a sustainable development goal. And for any service coverage to be effective, quality is paramount. The burden has been spoken about at length by the past speakers, but suffice it to remember that 1 in 10 have uncorrected refractive errors for distance, and 1 in 3 have near vision impairment. So, how do we define unmet need? Somebody with binocular visual acuity of less than 6/12, who has no available correction, but improves to 6/12 or better with pinhole or best correction, represents the unmet need. Somebody who is less than 6/12 binocularly uncorrected has a pair of glasses, but does not correct with that to 6/12 or better, represents the undermet need. Met need, of course, is someone who walks in with a correction and has good visual acuity. This would be our dream figure for the future. So till now, we used to talk about refractive error coverage, which just talked about the proportion who received services. We now have to take it further to include good outcome. And so that would be the definition of effective refractive error coverage. In this schematic, somebody who can see does not have a need. Somebody who can see with the glasses they have has a met need. Similarly, somebody who could not see with the glasses, as I just said, was under met need, and somebody who does not have glasses has the unmet need. And so the formula includes that eREC is met need by met need plus undermet need plus unmet need into 100. Globally, eREC, as reported in 2019, is about 43% for distance vision and about 20.5% for near vision. The good news is it has improved by 19% since 2000. What this also means is that the undermet need represents the quality gap and the unmet need, the coverage gap. Refractive error coverage may look as big as 44, but effective refractive error coverage is still only 36%. eREC for near vision is being looked at more closely now. And if a person is less than N6 uncorrected, has a pair of glasses which do not improve to N6 or better, that is again undermet need, does not have available correction, has unmet need, and somebody who can read with his glasses is again met need. The situation analysis, I have just taken one recent study to demonstrate this. eREC for distance is about 37.4, and that for near, about 31.8%. WHO has set a target for us that by 2030, we should have a 40% increase in effective refractive error coverage. This should include both near and distance vision, and so for the implication for India would be that we should move from 30% to about 70% in less than 6 years. So how does the WHO propose to do this? It has launched the SPECS 2030 initiative, which rests on 5 pillars, which are spelled by the acronym SPECS: improving access to services, building capacity of personnel, improving population education, reducing the cost, and strengthening the surveillance. The vision is, of course, that everyone who needs a correction will have one easily. In addition, it has also laid out desired outcomes at the country level. This looks like a busy slide, but we'll go through that very quickly. So for the services segment, we need to focus on policies, adopt quality standards, integrate procurement and inventory, and integrate with the primary health centers. I'm pretty sure Dr. Praveen will tell us more about that. Remember that the quality of the spectacles also have to be kept in mind, and there are prescribed indicators for this. Personnel has always been a challenge, but we hope to increase the workforce, train them, and foster innovation for screening. To me, it seems like Dr. Rao had also alluded that awareness and demand generation would be the key challenge. We need to implement campaigns, include eye health in other health programs, implement policies, and increase the demand for spectacles. For children, we will need to adopt as many models as are currently available in the country because no one size fits all. We will need to sensitively engage with the cultural perspectives to meet this demand. For adults, it has also been shown that the most near vision impairment happens in the working age group, so perhaps it may be worth considering interventions for demand generation at the workplace. Barriers to refractive error coverage, affordability is the main one, and a lack of felt need for presbyopia. This led us to do a study in Velo where we looked at presbyopia, and about 50% prevalence. And for their usual activities, it was seen that most of them who said they had a lack of felt need had a visual acuity of N12 or better. This may mean that demand generation be done with evidence, and maybe N12 can be the new cutoff if that is what it takes. As far as cost is concerned, insurance, trade barriers, and sustainable mechanisms need to be looked into, and effective ways have to be looked at to cut costs where ready-made specs can do it at 1/4 the cost. If there is no surveillance, there is no program. So we need to integrate this with the hospital information systems, periodically report eREC, and implement quality assurance programs. The WHO intends to do this by the private sector dialogues, the SPECS network, and the SPECS normative network to unify stakeholders, make evidence-based advocacy activities, and strengthen discussion. What can we do? We who are here in this hall today, we all need to advocate for the need to strengthen the services using tools that the WHO can provide. And I'm pretty sure each of us can adopt one area, whether it's a school or a locality, whatever it takes. Organizations and private sector representatives have been invited to take part in this. Lastly, I have just one word of caution. As of today, presbyopia brings every adult to an eye care provider in their lifetime. Current strategy for screening for preventable blindness like glaucoma rests on opportunistic screening. While focusing on eREC, we should not compromise on comprehensive eye examination. Thank you so much for your hearing.